Hello and greetings from Baltimore, Maryland, the home of the Peabody Institute at the Johns Hopkins University. My name is Abra Bush, and I'm the Senior Associate Dean of Institute Studies here at Peabody, and I'm delighted you could join us today for our conversation. Before we get started, I'd like to thank several Peabody staff members who are helping us out today and supporting in the background. First, as always, is Adam Scalici from Peabody's production team, who's monitoring the webinar and making sure we don't have any technical glitches. Patrick Wallen from the Dean's office, who is my support structure, will provide anything we might need. And Christina Mancior from Peabody's Launchpad is here to help me curate your questions. A really special thank you to all of them for helping us out. A few quick notes before we begin. I see that some of you are already hopping into the chat to say hello. Please make sure that you have to all panelists and attendees clicked, and go ahead and tell us you're here, tell us where you're from, and maybe a little bit about what brought you here today. If you have specific questions, go ahead and place those into the Q&A of the webinar so we can easily find them. Christina will be monitoring that and helping me curate those questions through the presentation. Please note that these presenters have agreed to allow us to record this. This session, along with all of the other sessions we've done in the Peabody Lunch and Learn series, are posted on the Peabody Keep Teaching website. Takes us a couple days to get it up there, but we'll get it up there very shortly and send you an email about it as soon as we can. And now, without further ado, I'm very pleased to welcome back to this series 3 presenters who were with us on July 8th, earlier in the year. Their bios are available on our website, but in the meantime, I'm very pleased to introduce to you 3 of our colleagues here at Hopkins. Dr. Stephen Gange is Executive Vice Provost of Johns Hopkins University and a Professor of Epidemiology. Jonathan Links, Dr. Jonathan Links, is Vice Provost and Chief Risk Officer, as well as Professor of Environmental Health and Engineering. And finally, Dr. Aaron Milstone is Professor of Pediatrics with a specialty in infectious diseases and a Johns Hopkins Health System hospital epidemiologist. Welcome to the 3 of you. Thanks so much again for being with us. All right, so when we spoke on July 8th, we had just passed 3 million cases in the United States of COVID-19, and there were 131 fatalities at that point recorded. As of this morning, I checked the Johns Hopkins dashboard. We are currently reporting more than 13 million confirmed cases in the United States and more than 286,000 deaths in this country alone. I also note that in March, the mortality rate was very, very high. I've seen statistics as high as about 25%. And I've seen that it's dropped to less than 2% today or so. So I'm curious, what in the world has happened here? I think that over the summer, we were concerned about what was going on, but it just seems to get worse and worse from what I can tell from the news. So I'll open it up to any one of you who'd like to take a stab at that.
Well, Abra, maybe I could start. I think that first of all, great to see so many of you participating today and from such diverse experiences. So thank you. It is a prediction that or data that we could have predicted, right? With knowledge of what is going on now. Right? It didn't have to be this way, but unfortunately, with all of the winds blowing against us, with how this COVID spreads, through respiratory dissemination through communities, and as both a politicization of COVID has taken place, as well as the onset of cold weather, as well as the onset of people getting fatigued after 8 months of trying to adhere to what can be very difficult considerations. Unfortunately, we are, where we are. And unfortunately, things are projected over the next several months to be rocky and continue to be rocky.
So Stephen, early on in this pandemic, I saw some data that showed that we knew that there would be a second wave of this virus. What were those predictions based on? And how do you in the public health sector know that? How did you know that was coming? You mentioned it's getting colder. You mentioned that fatigue and the politicization and all that, but early on there was data that we were going to see this surge. How did those get formulated?
So there are many models that are out there that are being used. In the famous words of a famous statistician, all models are wrong, but some are useful. I think the models for COVID have borne out broad trends along the lines of what we have seen, right? The models use data about human behavior, right? The degree to which people are congregate and living inside or interacting inside versus outside is a major factor that is, driving a lot of transmission. And so just by knowing how people tend to congregate, more in the colder weather versus in the summertime, helps inform our models. The other information about that go into that have to do with information about adherence to good public health measures, right? So the degree of mask use, the degree of distancing, some of which you can measure directly through surveys, some of which you can measure using other indicators as well. So, the modeling is complex. We have other similar types of respiratory diseases, flu, other coronaviruses that help inform these models. It's been hard, I would say, to predict some unanticipated aspects of resistance to using masks, for example, and the fact that may be concentrated in certain parts of the country, the fact there may be super spreader events that are in various communities that may contribute to broader transmission.
So as we look at what the data show for the next few months, we keep hearing on the news and reading in the press that we're in this surge situation. And I keep seeing that Anthony Fauci has said there'll be a surge upon a surge. What do the models predict for us for the next several months? And when can we start to see some of this abate a bit based on what you know about the models?
All the data that I've seen, and there are models and consensus models that take, summaries of existing models that help inform us. So, all of the data that I've seen continue to point to a high level of infections and increased burden on our healthcare system. And, in terms of our lagging indicators like mortality, there will be a continued increase over the next 2 to 3 months. I've seen models that tend to peak around the middle to end of January for cases, which would mean the late part of January and early part of February for hospitalizations and mortality. Again, that's highly variable, with a lot of uncertainty, but I think reflects the best, the best ensemble of different approaches.
So when we last spoke, gentlemen, Hopkins was planning on bringing students back to campus at the end of August for a start for the fall semester. Those of you that are not from Peabody and Johns Hopkins might not know that we in fact did not reopen, and Peabody and the rest of the university has been except for medicine and nursing, which needed to stay open. The rest of the university has been fully remote for the remainder of the fall semester. Um, the three of you were involved at the highest levels of making those decisions. And I would love for you to tell us, what are the sorts of metrics you look at in terms of making those decisions for a place like this? And what were the things really weighing on you in July and in August as those decisions were being made? And then what are you looking at in terms of our plans to return for the spring semester, which you should all know right now, we're planning on bringing students back to campus in the spring, at least as of today. That's sort of what's out there. What are you looking at in terms of what happens into spring? So two parts of that, fall and spring.
So let me take a stab at that. So first of all, we created a multi-phase plan. And this is a really important point because what you want to do, it's crazy as it sounds, is divorce planning from the actual decision. And by having multiple phases and planning for what each and every one of those phases looks like, you have the flexibility in decision making to go in a number of directions depending on public health conditions. So the notion of here's what our plan for the spring looks like is really not the way to go. Now, we do have a leading plan for the spring, but in all of our messaging to our community, we've distinguished between that plan as an aspiration, as a goal, and the decision about whether or not we enter a phase of operations that permits that plan to actually be realized in the spring. Our plan for the spring is consistent with going into phase 2 of our multi-phase approach. Phase 2 is a medium density phase of operation. We're currently in phase 1, which is low density. For the sake of completeness, I'll tell you there are 2 other phases. Phase 0, which is stay at home, and phase 3, which is return to normal. We would call it the new normal, whatever that looks like. That would be a high density, more routine operating posture. But so all the action is in current phase 1, which is low density on campus, and phase 2, medium density, the phase we aspire to in the spring. If we go into phase 2, we will be bringing students back to the dorms. We will be having in-person instruction to complement what is already happening on campus in phase 1, which is focused on lab and library research. So Hopkins as a university never, quote, closed. There's always been activity on campus, and it's just about the level of activity and the corresponding density of folk on campus. In all cases, we focus on what we call the 4 pillars of public health control: masking, distancing, hygiene, and room ventilation. And I'm sure we'll talk more about that in a bit. But those 4 pillars are what enable us in each of the phases to bring folk back on campus. So of course, everyone's required to wear a face covering. Everyone's required to keep a distance of at least 6 feet. In the labs, we also have an area requirement. It's now 150 square feet per person to complement the distance by itself. Hygiene, of course, with a focus on both personal hygiene in terms of hand washing and then cleaning of surfaces, and room ventilation in terms of air exchange, air filtration, replacement with fresh outside air, etc. But that means that even if we bring students back in the spring, if we go into phase 2 as we hope to do, it won't look like normal. So the residences will have 1 student per bedroom. There'll be a limit on sharing of bathrooms and bathroom fixtures. In person classes will be limited to under 50 students with spacing that is of desks and chairs that is determined for each and every classroom separately based on not just the size, but the configuration of the classroom, maintaining a 7.5-foot center to center spacing across the board. And so in general, if we quote, bring people back to campus as we hope to do in the spring, it's not going to look like normal times. It'll just be increased density compared to our current operating posture. Now, obviously, in the case of a conservatory, there are loads of additional considerations. And we've been working very closely with Abra and her Peabody colleagues to understand rehearsal rooms, to understand ensemble activities, and so on. I'm sure we'll talk more about that as well.
Definitely. Thanks, John. There are some questions coming into the Q&A about that as well that we'll address kind of as we go. In the meantime, based on what we know from the work we've been doing on campus, whether it's the research in the labs or the library reopening or any of the work that medicine and nursing have been doing, and what we know from peer institutions around the country who have had students back on campus, what have been the things that have worked to help them keep the virus levels down on campuses, and where have their challenges been based on what you know and have seen for the last few months?
Well, we certainly know that masking and distancing work. And the corresponding challenges are to masking and distancing, right? When students get together in close proximity in large groups without masks, that's the worst possible combo, and we're worried about that, and many colleges and universities have experienced that. We formed a cadre of safety ambassadors who, at least on campus, monitor activity in terms of masking and distancing to try to maintain compliance around it. And then, of course, our student affairs team knows about parties and other types of activities, and we monitor those as well. One of the things that some universities did in the fall, and more including us, are planning to do this spring, is to have mass asymptomatic testing. So we had a modest amount of that in the fall and are planning to very significantly ramp that up in the spring. You can think of it as an additional control measure to complement masking, distancing, hygiene, and room ventilation. It's not by itself a panacea, but it's another way to try to limit the spread by early detection of folk who are COVID positive and their close contacts, and in essence, removing them from circulation via isolation and quarantine.
And for this soprano, can you explain to me what that is? Masked testing?
So mass testing is in essence taking the testing that's going on all over the country for folk with symptoms and making it available for folk without symptoms who have no reason to believe they've been exposed, let alone infected with COVID, in an attempt to identify all those silent folk in the population. And as I say, take them out of circulation so they can't pass on the disease. In our case, we're going to be using saliva as the specimen. So undergraduates will be required to be tested twice a week. Graduate students, postdocs, faculty, and staff who are student facing will be required to be tested once a week, and then it'll be available on a voluntary basis for others once a week. Spit into a sample collection vial, gets tested, results returned within 24 hours, and a whole process on the back end to contact those who are COVID positive, to have them isolate and be clinically managed, and to interview them to understand what other Hopkins affiliates they may have been in close contact with.
So I've read that there are a variety of different kinds of tests. There are antigen tests, there are other kinds of tests. Could you give us just a quick primer on the different kinds of tests and what they show?
Sure. So there's fundamentally three broad types of tests. There's tests of the nucleic acid itself. So PCR-based tests, for example, that's what we'll be using. There's antigen tests, which also sense the presence of the virus. And there's antibody tests, which sense the body's reaction to a pre-existing exposure to the virus. Depending on the specifics of the test, the sensitivity and specificity, that is the fraction of people with the disease who the test identifies as positive, and the fraction of people without the disease who the test identifies as negative, vary. So the accuracy of these tests can vary. The advantage of mass testing is you're testing people over and over again throughout the semester, not just one time, as you normally would with a medical diagnostic test. And so the idea is to do it frequently enough to pick up people.
And so someone asked in the chat, how did you get ethics approval to require testing of all undergrads, and who gets the test?
Well, so it's actually not an ethics question, frankly. It's a legal question. And we have purview over our students in terms of their access to the services we offer, including coursework and so on. And so if you want to be a student in good standing who can access courses, who can come onto campus, et cetera, we can mandate testing. We can do the same thing for faculty and staff as employees. Working at a university and coming onto campus are privileges, not entitlements.
Right. And we have alternatives for them, right? You know, if you don't want to participate, right, you can choose not to be tested, but you can't come on campus and be in class. And so, we are, to the best extent possible, providing remote and online alternatives. Certainly any student that's sick, we don't want coming to class, and we want for them to continue, again, to the extent possible, for them to continue their academic experience. But as John said, we do have certain expectations for being on campus that we can enforce.
Thank you. There are a number of questions kind of coming in around masking. And for that reason, I would like to turn to that, to the masking piece. It's been very clear from the beginning that for anyone on campus at Johns Hopkins, we have to be masked. But there are all kinds of challenges with that for us as instrumentalists and as singers. And so I would love to hear you talk about the importance of masks. And we've traditionally sort of steered clear of what masks are better, that conversation, unless there is something specific around that you'd like to tell us today. The other thing that I would love to have you talk about, any of you talk about, is there has been that some of the studies that have been done that show that that instrument bells and things should be masked. I would just love to hear you sort of talk about that. There is a kind of a debate in the music school world to mask bells or not to mask bells. There are people that say it stifles the sound. Why is that important? I think is my question. So.
Can I start by making a comment about mask use? We think of mask use as, everyone says universal masking, wear a mask all the time, and that is our goal. But there are many times when people aren't wearing their mask or take their mask off. I mean, an example is someone drinking coffee or someone sitting down to have a snack. So in a work environment, there are times where people are unmasked. So instrumentalists wouldn't be the only time where we've encountered people that are unmasked in any environment. And the goal is to really risk mitigate. So the idea of masks is to risk mitigate. Say you're walking down the hall, you're getting on an elevator, there are going to be times where you're going to be in closer proximity to people than you may otherwise want to be. If you get in an elevator, even if you limit the density to someone in each corner, you still may be less than 6 feet apart. So I think the idea of universal masking is really to reduce the risk of not only the people around you from aerosols, but also the risk of contamination of the environment as you're standing somewhere coughing onto a railing or coughing into your hands and touching. So the masks do not only protect the airspace around and people that are directly around you, but they also reduce contamination of the environment. So I think it is an important question about musicians not wearing masks, but similar, I'd say, to people having lunch when they're at work, or people having snacks when they're at work, or people taking medicine when they're at work. There are going to be times when people have to take their mask off. And what we try to do then is figure out how to do that safely. And I know that the group here and others, I'm sure on this call, have spent an inordinate amount of time thinking of how we can safely do that to protect people within those environments when they do either put their flute under the mask or have a slit in the mask. But I don't think that this is a true outlier. It is unique, but like everything else, the goal should be risk mitigation.
So
Go ahead.
sorry, in that regard, let's talk for a minute about the different modes of transmission of the coronavirus. And, you know, I'm sure it's a bit confusing to hear about 6 feet, but then to focus on room ventilation and then on cleaning surfaces and so on, like what's going on. So the primary way in which an infected person introduces coronavirus into the environment and thereby exposes other people is through respiratory aerosols. And I'm purposely using the word aerosol instead of the more specific word droplet, which usually means a large aerosol, a water droplet that is physically bigger. So they're really, in talking and singing and playing a wind instrument, there are a variety of aerosol sizes that are emitted by a person. If the person is coughing or sneezing, it's typically going to be larger size aerosols. Let's call those respiratory droplets. And early on in the pandemic, I would say the primary, if not almost exclusive focus on how the coronavirus was released into the environment and transmitted to another person was on these larger respiratory droplets from coughing or sneezing. Those larger respiratory droplets tend to settle out of the air rapidly over a short distance just by gravity. And that's where the magic 6-foot rule came. And honestly, 6 feet isn't some scientific great number. In the European Union, it's 1 meter. And the fact of the matter is, it's just sort of how big a distance do you want to assure yourself that as great a fraction of those large respiratory droplets have settled out as possible. And so in this country, it's 6 feet. But the notion is that with greater distance, the large droplets from coughing and sneezing aren't going to reach you. You then put on a face covering, and to the extent we can argue about different face coverings and how much they filter and so on and so forth, it is a certainty that the larger the droplet, the larger the aerosol, the easier it is for a face covering to filter it out. By the way, that works in both directions. The face mask is agnostic to whether you're the one exhaling the aerosol or the aerosol is you're inhaling it through the face covering. So the face covering protects you and it protects other people by exactly the same filtering mechanism. So early on, everyone was focused on these larger aerosols, the respiratory droplets. They are still the primary mode of transmission. But folk came to appreciate something that in aerosol science has been known for decades, that we exhale a polydisperse spectrum of aerosol sizes, and that there are smaller aerosols that do not readily settle out over a short amount of time in a short amount of distance, that in fact can stay airborne for a considerable period of time and disperse throughout a room. And in a room with no air exchange, that means all of those particles remain airborne, and the next group comes in and they're exposed to them, and the next group comes in and they're exposed to them. And so room ventilation, which ought to have been paid attention to from the beginning, became the fashionable thing to talk about. And so what you really want to do is have a lot of air exchanges per hour so that the air is refreshed. And it's refreshed in two ways, particularly in a commercial setting like a school. The first is it goes through filters and is recirculated back into the room. And so with the appropriate filters, a rating of MERV 13 or higher, for example, a lot of those aerosols are filtered out of the air as it's recirculated. The second thing that happens with air exchange is that a fraction of the air is actually new air drawn in from the outdoors. So it's fresh air that is then diluting the air that had already been in the building, and a certain fraction, of course, is exhausted to the outside. And so air exchange and filtration become important methods to control the smaller aerosols that stay airborne. And that's why masking and distancing for the larger respiratory droplets and room ventilation for the smaller aerosols all need to be attended to. Then finally, and it's honestly a distant third, the aerosols ultimately settle out, particularly as we've been talking about the large respiratory droplets. And so they're on surfaces. Plus you have infected people who are, touching their nose and mouth and then touching surfaces. And so the surfaces become contaminated. And then other folk touch those surfaces and touch their face, usually unconsciously. In fact, I entertain myself during Zoom calls by watching people touch their face all call long, and thereby transmit virus that was on the surface to their face, and eyes, nose, and mouth are the portals of entry. Because I'm a belt and suspenders kind of guy, I do wipe down my groceries, and I do pay attention to surface cleaning, but it is really a distant third route of transmission compared to the respiratory droplets, which are mitigated by the masking and distancing, and the smaller aerosols, which are mitigated by proper room ventilation.
So let me just say, John, you have an odd sense of fun by watching us touch our faces during these Zoom calls, but I'm glad to know that now. I'll be much more self-conscious in all moments in which you were present. So thank you for that. I'm curious, Aaron, are you wiping down your groceries or are you not?
No, and you probably see me sit here and touch my face a lot too during the call. Not into my mouth or into my nose or eyes, but no, I think John's right. And what I tell people is what's most important is washing your hands. So I do not wipe my groceries down, but before I eat, I wash my hands, and before I prepare food, I wash my hands. So I think there's and getting back to, I guess I'd add two comments to John's kind of thorough description of the transmission dynamics. One is that if you want to rely on your ventilation in your institution, you need to check to make sure that it actually is filtered, because most institutions until now didn't actually have these high particle filters that the air was getting so even in some hospitals, air is just being recirculated and it's not actually getting filtered. In others, it does get ventilated outside and doesn't get recirculated. But if you're in a place where it is recirculated, please make sure that it is going through filtration. And the second point that I wanted to make is how we think most of this is happening. As John mentioned, we do investigate. We've investigated across our health system and university hundreds of people who've gotten COVID, unfortunately. And in most of those cases, the behaviors are the ones that you would expect as high risk. They're people that are going to, it's what you hear about in the paper. They're going to parties, they're going to indoor restaurants and bars. They're not people that are staying at home, wiping down groceries. I mean, taking these extra precautions. So I think that everything we think about should be how we mitigate risk, starting with the most common things first. And that's why John was reemphasizing, like I said, washing your hands is so important. Wearing a mask is so important. Some of these other things may help reduce the very, very unlikely causes. But right now, what we're still seeing are the major causes, and not enough people are doing the basic things to prevent themselves from getting exposed from these like major risk areres. So I'm not sure I answered your question, but yeah, I don't wipe down my groceries before I bring them in the house. I don't let my packages sit outside for 24 hours before I bring them inside.
Just one other thing to add, the importance of fresh air when possible, right? You know, that is also, you know, I think, you know, the basic, you know, idea of when possible, conduct things outside. You know, outside is not a panacea, right? You know, it doesn't, you know, automatically prevent transmission, but like all of these other processes and things that we try to put into place, it helps, right? And so if you think about all of these as building a barrier, right? Each of these things is adding to that barrier that makes it harder to transmit. And you know, our view is, and I think all of the successful you know, organizations have taken a multifaceted approach to try to use all of these things together and not rely on one.
So let me just pick up on that, and let's now turn our attention to music. And so masks with slits in them and bell covers with filters and so on. So I am a fan of the University of Colorado, University of Maryland work. And it's certainly what we've incorporated into our thinking at Hopkins with Peabody. There's not one thing that's doing it. So it's not the mask and what happens when you put a slit in it. It's not the bell cover. It's not the distance. It's not the room ventilation. It's all of it together. Everything is chipping away at transmission. And so we're not expecting any one control measure to be bulletproof. And we're not so naive, honestly, as to consider even all of them in ensemble as being 100% bulletproof. But it's a notion of chipping away at the transmission until the probability of residual transmission is low enough that the benefits of the activity, in-person instruction, ensemble rehearsal, et cetera, outweigh what at that point are low residual risks.
So one of our colleagues from Florida has posted a couple of questions in the Q&A that relate to this that I'd love to share with you. One of his questions is around masking. He says, cutting holes in masks and blowing through the hole clearly defeats the purpose of the mask. That's clearly one of the recommendations from the Colorado study. And John, I'd love to have you comment on that.
Yeah, so first of all, another thing that I entertain myself with is to see how people wear their masks, right? You got to cover your nose as well as your mouth. And by the way, using the mask to simply cover your chin isn't doing anything, since your chin is not an emitter. And so the mask has to properly be covering your nose and your mouth. You then cut a slit in the mask. First of all, it's still covering your nose, so it's still doing some good. But it is obviously the case that the instrument you're blowing through the slit in your mask is emitting aerosols. That's why I think a bell cover that is either at a minimum the same mask material, or even better, has a filter in it is the way to go. And it's known that singing and playing a wind instrument is introducing more aerosol into the environment than speaking, and speaking's emitting more aerosol into the environment than just breathing, but all of them are introducing aerosol into the environment. And so what you're trying to do is, as Stephen said, put up these multiple barriers or multiple control measures that are chipping away at transmission. But I'm a big fan of a mask with a slit in it as opposed to no mask. But you need the bell cover as well. And oh, by the way, you need distancing as well.
So there was another comment that Dr. Helton made, and he said no university is going to test every room, and that air exchange varies by room, regardless of the rating of the filters and the HVAC systems. Someone else asked, who's actually testing these ventilation systems, and how are we testing those ventilation systems? And John, I have to say, I think we've tested every tiny little room.
We did.
So, yeah.
We did. So we bit the bullet months ago when we recognized the importance of room ventilation, and identified every classroom, and in the case of Peabody, rehearsal space, and actually ran tests. Now, we knew that we had not optimized ventilation, so we did the ventilation optimization first. So it's normal practice, of course, that you turn down the ventilation evenings and weekends. So the very first thing we did was to run the HVAC systems flat out 24/7. We then looked at all the filters, back to Aaron's point, in our systems, and in fact had to upgrade a number of filters. Now, Peabody is one of the oldest buildings, has some of the most challenging HVAC and ventilation issues, and we weren't able to get everything to the level we wanted. But we did bring in an engineering firm that then measured air exchange, and we know overall air exchange rate, number of air exchanges per hour. We know fractional makeup of fresh air from the outside. We flat out did measure all of that. And for rooms that are not as good in terms of ventilation, we take that into account in terms of scheduling the use of those rooms, in terms of how long an activity can go in the room before there needs to be a period with no activity in the room to allow for air exchange without any further introduction of aerosol into the room, and so on.
Okay. Another question that popped up from the group is this: there are some institutions, some colleges, and even performing arts high schools who have permitted wind instruments and singers to function on site, especially if they're masked and distanced appropriately. And there are other institutions who have not permitted those same players to be on campus working collaboratively at all, right? We have clearly made our guidelines around them being on site and being able to collaborate in the phase 2 reopening that you indicated, John, but with masking and distancing. What would you say to those colleagues of mine who are dealing with institutions that have taken the very super conservative approach? And they're, frankly, they're wrestling with that, right? Like, how do they provide the best level of education to the students when they can't play either on site or they are relegated to their dorm rooms in order to play their instruments?
So I'm going to answer in two ways. First, a focus on public health. So public health conditions, I mean, right now it's bad everywhere, but until relatively recently, there were meaningful variations in public health conditions throughout the country. And if a college or university or a performing arts high school was in a location experiencing very low community transmission, The operating posture might, in a very valid way, look quite different than in another location of a similarly situated school with higher community transmission and a need to be more conservative. And so just from a public health perspective, there are valid differences in operating posture. I think those become less now because the public health conditions are so bad everywhere. Now I'm going to take it from a risk appetite and risk benefit perspective. There are schools and there are school communities for whom more risk is acceptable because of the benefits of the activities that are conveying that risk, meaning the in-person activities. And that becomes a value judgment as much as a scientific judgment about what makes sense. What I think we take exception to is a sort of single-minded focus on the benefits without due consideration of the risks, or with a scientifically inaccurate diminishing of the risks or their perception in relation to the benefits when making these decisions.
So, Aaron and Stephen, I've heard a number of my colleagues around the country say to me privately, how do we discuss with our university or our administration, how do we talk about the fact we feel afraid going back into our studio? You know, many of our colleagues even chiming in here in the chat and in the Q&A are saying, my university isn't testing every room. They forced us back, right? I mean, I've got colleagues in South Dakota with a positivity rate off the charts who have been afraid to go back into their voice studios because they've been told to get back to campus, and yet there's teaching singing. How would you recommend that a faculty member in music or in any area, frankly, how they protect themselves, number one, in these circumstances? And number two, Stephen particularly, how would you suggest that they approach a conversation with leadership about this topic?
So, really good questions, really tough questions. I think that at least the way that we've approached this is to recognize some basics, right? I think that if there's misunderstanding or misinformation about even some basics about the transmission of COVID, you have no place to go. And so I think the data are, could not be stronger for the basics. There's plenty of, sites, the CDC and other local health departments, I think, have been working hard to make sure that people understand the fundamentals of this disease. And certainly this session is attempting to do the same. I think that if you don't have that, then, you have to start at that level. I mean, we've seen, I think, I'm sure others have seen, people who report, I saw one report on CNN of a nurse, who said some of their patients were still denying, right, that this was an actual virus, right, that this was transmissible, right? Those are the basics that we have to just overcome to have the next conversation. And I would encourage everyone to use the resources that are out there on the CDC website, your local health department or state health department, the Johns Hopkins coronavirus site, other resources that are out there to help you with that. Given that, right, I think the approaching this as a multifactorial, situation, right? And saying, look, we need to make sure that there are a spectrum of protections in place, right? And it may be that for some certain situations, such as we want to have wind instruments, right? Or we want to have singers, that some of those protections can't be or aren't appropriate for the scenario. In my mind, then that would emphasize the importance of other potential factors, right? If you're going to get singers together, can you get them outside, right? Can you ensure that their distance and they're in a room that's very well ventilated, right? You may have, your normal practices in a small space, but decide to utilize a auditorium or stage that allows for de-distancing, right? So going to what John and Aaron have said, of risk mitigation, right? If you have multiple tools and view this as an opportunity to use multiple approaches, I think one approach would be, if you can't use masking, right, then try to beef up the other approaches, right, and emphasize where possible that you need to build as many barriers as possible. I realize, we all know testing is not cheap, right? Testing of capacity issues, organizational issues. I know that a number of colleges and universities are actually relying on their public health setting to do the testing for them and not offering it. That may be a matter of again, instituting some expectation that if you have an expectation that you will be tested, right, even if you don't do the testing yourself, you can help set, again, some of these other levers that you have access to that might mitigate some of the other concerns.
Ask Aaron. I remember a conversation with you, Aaron, in the summer in which we were talking about masking and face shields and things. And you sort of very clearly laid out that there are only small differences in sort of the masking and the face coverings in the clinical setting. And I would love for you to sort of talk a little bit about that. And if you want to follow up on Stephen first, that's fine too.
Sure. No, I really like the way Stephen outlined it. The only thing I would add is just giving people, as you said, I think it's important to give people the opportunity and space to voice their concerns. I think oftentimes we found, we've been dealing with this since February when we had our first cases, and even now there are still parts of the hospital and university that are just seeing it's touching them for the first time, whether it's someone in a lab or someone in a studio or someone who hasn't had it really touch home for them, that are getting their first experience and getting very anxious. So I think, and although we think we've done such a great job educating, we think that science is informing. A lot of people haven't heard the science, they haven't read the education because it wasn't in their house or in their backyard. So I think having this ongoing repurposing of information to remind people, especially what your organization is doing, because I'm sure they're all doing a lot, but a lot of the staff, because they haven't really been listening, or they've been listening but not hearing it all, they might not know all the steps that have been put in place. I think continuing to reiterate all the precautions that have been put in place to protect people, and how in the workplace that mostly has been very effective. I think that's a really important message, is this reassurance that workplace protections have been relatively successful. And with that, whenever we have one of these occurrences, we are quick to recommend our support team. So we have a emotional and social support team that we try to send into these places that can actually really listen to people's concerns and provide them with emotional support to get through the challenges that they're facing personally, both at work and at home, because those are real as well. The other thing that this group may be great is shared experience, because I know early on when we could point to another organization and say, here's an organization that's done this, they haven't had problems with this, it's been successful. Those, even in a time when there isn't a lot of data and there aren't perfect studies being done, or they won't be done for another year until we have enough data. Having some of those powerful anecdotes are important, because what most people are hearing or consuming online are the scare tactic, fearful anecdotes of the 1 in a million, something happened, like I flew in an airplane, everyone got COVID. That hasn't happened. I mean, flying actually is thought to be pretty safe, but you don't hear that very much. Everyone just hears the fear of flying. So I do think there are things that can still be done to reassure and educate that will help people move forward. In terms of your question about masking and face shields, we have, in our healthcare environment, really just required masks. We only require face shields for close contact with patients. And it's that idea that, as John went back to, it's really playing probability. If you're 6 feet or more from someone, we think your risk of exposure is low. If you get within that range and it's someone who's unmasked, then having eye protection, because your eyes are a vulnerable mucous membrane that the virus can interact with. So if someone were to, those medium-sized, large droplets, if they were to cough or speak loudly or even sing, and they were to contact your eyes, then that would put you at risk. So I have even advised people outside of healthcare that if you are going to find yourself in a setting around other people who may not be masked, which in many parts of the country is still happening, and you are uncomfortable, then that extra face or eye protection may help. The mask will help, but the eye protection may protect your eyes. So I think there are some settings and where that may be of value.
So thank you. That's really helpful. I also remember a moment in our summer conversation in which the issue of plexiglass came up, and it has once again come up in the Q&A. And so, John, please tell us your opinion about the use of plexiglass.
Yeah, I find it in general a distraction. You can think of it as a giant face mask. It is not a substitute for anything. And in fact, going back to the U of Colorado, U of Maryland work, it can actually interfere with room ventilation, thereby causing problems. And particularly if its presence sort of lulls someone into a false sense of confidence and they're not masking or properly distancing, I'm just not a fan. I mean, I think there are very specific uses, such as in a grocery store or at the post office. I'm fine with that. It makes sense to me. But in general, I don't like plexiglass.
So I've read in some articles that plexiglass can actually inhibit the flow of air in a room and can actually make it worse in terms
yeah, well,
of,
I mean, we've just talked a bit about the importance of room ventilation for the smaller aerosols, and large plexiglass barriers, particularly multiple plexiglass barriers around each person, definitely is interfering with air exchange within the room and with the HVAC system.
so interesting, because plexiglass is like a new weed, isn't it? It's like everywhere now. And I think people rely on it in a way that is not kind of based on science and on research.
Yeah, I also, in that same vein, I'm looking at the chat and the Q&A. There's a comment about N95 masks, and I'm going to say something strong just because. I think people are kidding themselves with N95 masks. An N95 mask is a phenomenal mask when it's fit tested and worn properly. And if it's not fit tested or worn properly, it's not a phenomenal mask, because all it can do is filter the air you're inhaling through it, not the air you're inhaling around it. And so if a university is just handing out N95s, no fit testing, no proper sizing, and so on, to me, it's terrible, because it's consuming important healthcare PPE. It's providing a very false sense of security. And frankly, it's not something on its own, even when properly fit tested, is like the answer. All of us have been emphasizing it's the ensemble of control measures that's doing the trick, not one magic bullet.
Actually, along those lines,
Yeah.
again, looking at the Q&A, the one other parameter that we haven't talked about is time, right? And time of exposure, which, is one of the, again, factors that may contribute. The longer you're exposed, the greater risk you have. And there's a question about, length of performances, which I think is very valid. I do think this is one area where there is more leeway. I know many, performance groups have altered their repertoire to minimize time, to minimize, instruments. Our own, BSO, right, started out with just string performances, and then transitioned to wind performances. I do think that is, again, another lever that we have for building barriers for protection, and would certainly, encourage, a smaller, 15, 20-minute string ensemble versus, a smaller entire symphony.
One other thing we haven't talked about, can I add, is our super spreader events. And a really important concept of preventing and stopping the pandemic is to prevent a single person from exposing a lot of people. If it's one student, one teacher, that obviously is still not acceptable, but the main driver or the concern is one person spreading to 25 or 30 people at a time. And what I think for many of us, the great challenge is we don't know who the super spreaders are. And in many cases, we don't even know why someone is a super spreader compared to someone else. So many of you have probably heard about that report of the chorus rehearsal where there was one person in the back and almost everyone else in the entire room got COVID. Why that person was special and was able to spread it to everyone, we don't know. I'm sure it was not the only participant in a chorus that has had COVID in the last 9 months. But that's what we're trying to protect against. And I think what John and Stephen are also, when we talk about plexiglass and not fit tested N95s and these other measures that people try to add in, they are not going to protect against an event like that. What's going to really help is reducing density, trying to keep people distant, like those basic tenets is what is really going to protect a larger proportion of the population and prevent this from amplifying faster.
Thank you. There are a couple more questions in the Q&A I want to get to, and then I want to turn our attention to vaccines for just a moment if we can. Aaron, you do pediatric infectious disease. We have a number of folks on this in the attendee list who teach in the community music school world and teach kids, or as one of the questions has asked, she teaches in a K-8 school. She says there are studies that say that younger children are less likely to spread the virus. Are those reliable at this point?
So I've seen those studies go both ways. I've seen some studies suggest that within households, children may not be as likely to spread, and others do. One of the reason those studies are still challenging is you can imagine if you're a parent and you're at home with your family and you get sick, you're going to have a lot of interaction with your kids. So the likelihood of you spreading it to all of your kids is greater. If you're a child in that household and you get sick, your parents will push you and separate you from your siblings, and then your siblings may not get sick. So it may appear that you're not as likely to spread. So I do think that some of these studies are a little bit influenced based on what normal dynamics are like of families and how they interact. So I don't think that, I do think we have plenty of data that has shown that kids can be spreaders. There are studies out of Chicago that show that kids can have as high or higher viral loads in their nose around the time of symptom onset as adults can. So I wouldn't another example of, I wouldn't reassure yourself by thinking that kids aren't as likely to spread, especially if in a setting where you may have close interaction. Now, with that said, many K through 8 schools have successfully reopened and done pretty well during a time of lower incidence in the fall. So many schools did open up in September, October for lower school children and had good plans of hand washing and universal masking and distancing. And they were able to do that with little spread. Whether that will be able to remain a successful strategy as the prevalence increases is still going to be a challenge, because I think one of the other things we keep reiterating is this probability. As the prevalence and numbers increase tenfold, the probability of you interacting with someone unknowingly increases quite a bit. So that's the great challenge ahead. For successful programs in the fall may not be successful programs come January, because the characteristics and communities will likely be very different.
Thank you. There's one more question in the Q&A, and John, this is really for you. If this person talks about teaching privately and can't open the windows and is concerned about the space that they have and the ventilation, and asking for tips of how to increase ventilation, or you mentioned filtering. Do you have any kind of quick tips for folks that they might be able to utilize in order to increase ventilation? I just touched my face. I'm sorry, John.
Oh, you entertained me. Thank you. So fundamentally, in a home environment, you can increase ventilation. You can open the window. You can turn on a fan. You can actually increase cross ventilation by opening windows opposing each other in the same room, in multiple rooms, and then running fans. So there are easy ways to do it. Of course, you have to be in control of the home, so to speak. And at this point, I personally would not be going into anyone else's home. So I wouldn't be the traveling music teacher that's going into the student's home. It would have to be students coming into my home. By the way, I wouldn't be particularly crazy about students coming into my home these days, just to be blunt about it. If it's a commercial space, or in a college setting or other school setting, you may not have direct control the way you would over your own home, but there are still things you can do. Now, back to Peabody. So there are some terrible rooms at Peabody. Let's just be blunt about it. It's a very old building. It doesn't, it has the worst HVAC of any place in the university.
You're killing me here.
But we've worked wonders in many of the spaces, but there are still rooms that even after working wonders are just not where we'd like to have much activity going on.
So John, if I may make a comment, our building, just so those of you know, part of our building was built in 1865. And as a result, it does not have high-tech HVAC in it. It's an old facility. And so John, please continue.
Honestly, there are many other buildings at the university where the offices in particular are not much better than some of the situations I just described at Peabody. And what are we telling faculty? No, you're not going to meet with a student in your office that has a painted shut window and no real air exchange going on in that space. You're going to meet someplace else with them. And I think there are just certain settings, particularly right now with the surge, where it just doesn't make sense to have certain activities in those settings.
Thank you. All right, I do want to turn to vaccines for just a moment, if we can. These vaccines that we keep hearing about have been developed very quickly in comparison to other vaccines, and there is a lot of there's been a lot of press around whether or not they're going to be safe and effective. And so I would love for any of you, to talk about sort of how you are approaching this in your own lives, and why this has happened so quickly, and how, and is there reason to be concerned for the general public to take these as they roll out in the next? I mean, clearly they're not going to, I believe I'm not going to get a vaccine anytime soon. So talk to me a little bit about that whole process and what you envision is going to occur.
Abra, maybe I can start. So, there have been 3 really positive results through three different vaccines that have shown positive results with very high efficacy, greater than 90%. And again, to interpret that, what it means, that's the percent reduction in the occurrence of infections in those that are vaccinated as compared to a placebo control. Right. So the latest, results that were actually just came out yesterday, the Moderna vaccine published some more of their data. Right. They had 30,000 people in their study. Right. And they had, their vaccine has 2 doses. Right. And for the people that got the placebo, 185 people got COVID. For those that were vaccinated with their candidate vaccine, only 11 people got COVID, right? And so, the trials that are being done are big studies, are being done by reputable companies, and are being evaluated critically. When looking at these data, it's important to look at different subgroups. How many older people did you have? Younger people did you have? It's important to look at the severity of disease. Actually, the Moderna results actually showed that no one who got the vaccine got severe COVID infection, right? There were 0 cases versus 30 in the placebo group. So all of this is very positive. And it is done with funding from governments, but is not, under direct government control. So you have a checks and balances, and that is the role of our federal agencies like the FDA and equivalent in the EU, who collect the data from the companies and scrutinize it. And it takes time to do that, right? They submit reams and reams and reams of safety data. These data are typically reviewed by an independent body that's required by the agencies, people who don't have a financial interest and who don't have scientific conflicts. So I would say the community really should have faith in the process, right? Again, despite all of what has happened through 2020, the public health process is working, right? This has been done quickly. It's partly because it's a relatively easy vaccine, right? For someone like myself who works in HIV, which is a terrible virus, right? Because it attacks your immune system, and it's a retrovirus because it actually stays in your system for a long period of time. This is a relatively easy vaccine. You can just take the, pieces of the virus and expose people to it, and they have an immune response. Generally, that's pretty good. So as long as you're not giving them the full virus and just a piece of it, they can actually respond quite well. So I would say, please, let the regulators do their job of evaluating the data over the next several weeks. The data were just submitted. I think people should have faith in the system, and hopefully within several weeks there will be approval for these vaccines, and that will be the end of the beginning, right? And the next step will be ramping up manufacturing and distribution of the vaccines, and that's going to be, frankly, I think, the next challenge. Even today, there is a CDC advisory panel that's voting on how vaccine should be distributed. It probably will be that those who are at highest risk will be, and those who are healthcare workers or on the front lines are the highest priority, right? And so, if a vaccine is approved and manufacturing goes smoothly, late December, early January, when the first doses are going to be distributed, it's not, you're right, Abra, it's not going to go to all of us. Maybe it'll go to Aaron, but it won't go to the rest of us. But the frontline workers and those at highest risk will get it first. And hopefully, if there aren't any bumps in the road, by this spring and early this summer, there should be mass distribution of the vaccine.
So that was my next
Can I
Go ahead,
just
Aaron.
get at the fear in that question? Because there is a lot of fear about a new vaccine. And I think we need to address that head on, because the anti-vaccine community has really bred over the last couple of decades fear in vaccines. And what I would encourage people to be fearful of now is COVID. People are dying from COVID, and we don't even know what are going to be the long-term complications of COVID. As I was asked earlier, what are going to be the long-term complications of lung disease in people who are singers? So I think right now it's not that COVID's going to go away. If you don't get the vaccine, you will get COVID. This virus will continue to run through the population until it's infected everyone. So you will either get COVID or you will get the vaccine. And I think that the probability of having a bad outcome from this infection will far exceed any probability of a reaction to the vaccine. So I think we need to kind of flip the paradigm here and make people recognize that the fear here should be on the what ifs and the known challenges and complications of COVID, and realize that this vaccine is really going to help save a lot of people. And just to address the Q&A, I know that at Hopkins, we are not going to tell providers what vaccine they would be getting, because we're not going to know. It's going to be, you're going to get a vaccine, and what's there is the one you're going to get, because we're not going to, operationally, I don't think anyone's going to be able to let people cherry pick which one they want to get.
So that leads to my next question. At some point, I hope, we'll get enough people vaccinated against this thing that we can burn our masks or at least throw them away. What is that point? You talked, Stephen, about hopefully by summer-ish, we'll have enough vaccines out there that at least most of us will have gotten them or could have gotten them. When can we burn our masks? Because I'd like to burn mine.
So this underlies the good idea of herd immunity. Right? We hear a lot about herd immunity, and it's often portrayed as bad. Allowing the infection to run rampant through the population and get enough people positive so that there's less likelihood of being infected is a terrible idea. Right? It is a terrible public health idea. The complications that Aaron mentioned are unknown. There are very scary reports of, as you said, Abra, people with long-term consequences, people with cardiac consequences and continued infirmity. There's no reason to be talking about letting this spread throughout the population. On the flip side, right, herd immunity in its good perspective is vaccinating enough of the population so that the risk of coming in contact with someone is low. The estimates that I've seen, aim for a herd immunity or a vaccination rate of a high percentage, right? As Aaron and John have emphasized, this is a highly transmissible virus. If it had a low barrier, we could probably get away with a vaccination rate that was much lower. But we're going to need vaccination rates that are relatively high. And so, 80, 90%, right, are if not higher, are targets that we really should aim for. And so, I don't think people should be, burning their masks in January, right? I think people should be following how is the vaccination effort going. that is, there may be bumps in the road. We all hope there aren't. And, there may be subsets of groups who dig in their heels and don't view this as a priority. We need to know that. And I think continue to take our basic measures until we get at a level that, the community at a high level is protected.
So do we think
maybe in January people can burn their 2020 mask and don a 2021 mask that will bring some optimism for the year to come?
There you go.
That's actually, in thinking about this conversation, that's what I might do.
So do you think this is going to be a yearly vaccine that we're going to need to get, like a flu shot, or is this one and done, or do we have any idea yet?
We don't.
Yeah, that's a good question. Go ahead, Aaron.
No, I was going to say we don't have a ton of data on lasting immunity from the vaccine. The one, I was starting to type that in, but couldn't do it fast enough. The one good thing is that the virus does not seem to be changing quickly like influenza does. So influenza changes and mutates a lot, which is why each year we need a new vaccine. There's not evidence yet that this virus is doing that quickly. So we hope that the vaccine will work. Whether it will sustain, that immunity will sustain from the vaccine, I think we have to wait and see. But we're hopeful.
So we're ever hopeful we're going to return to campus in the spring as well. What are the metrics that you gentlemen are going to be looking at for Johns Hopkins as we think about coming back?
So there's really two buckets of considerations. The first is public health conditions around the campuses. So what's happening in Baltimore and the state of Maryland, what's happening in DC, obviously what's happening in the rest of the country, since students would be returning from elsewhere in many cases. We're going to be paying a lot of attention to that. And the what's happening is a combination of sort of at that moment what's happening, as well as the trajectory of conditions based on both what the shape of the curves are looking like at that point, as well as the modeling that Stephen spoke about earlier. And then the second bucket of considerations have to do with our own capabilities and capacity. So we know that testing, just as a prime example, is an important additional control measure. And we are ramping up right now with the goal of being able to handle multiple thousands of tests a day come January. Reaching that goal versus not reaching that goal is a pretty meaningful difference in terms of our thinking that will be combined with what we're seeing in terms of public health conditions. Students and their families are frustrated when we don't make an early decision. And what I always say is, it's very easy to make an early decision. No, we're not opening. Oh, you don't like that decision? Then you got to wait as long as you possibly can, honestly, to make a decision so you have the most current information on public health conditions and trajectory.
I want to thank all of you. The information that you provide to our music community across this country and frankly across the world through these talks has been extraordinarily helpful to us. I feel so privileged to work at a place like Hopkins where I have access to people like you every day to ask random questions about these matters. And I note that so many of my friends and colleagues don't have that access. And you've done a tremendous service to our field by agreeing to serve on these panels. I hope that, frankly, we don't have another conversation like this. But I want to leave the door open to another conversation 5 or 6 months from now about where we are in this country and where things continue to be. And in the meantime, I want to thank each of you profusely for your time today and for the incredible advice you've provided. I want to note to all of you that have attended this session and all of the sessions that we do put a full list of the sessions and archived on our Keep Teaching website. Please don't hesitate to take a look at the July 8th conversation that we had with these gentlemen. You can compare and contrast to where we are today. And I want you all to know that we are planning another series of these events every other week through the spring semester. I'm in the process of putting those together now. So stay tuned for further information about the topics that we will be considering. I finally want you all to know that after this session, a short survey will pop up in your browser. If you'll complete that, it really helps us to get feedback about what we're doing and helps us to know what's on your mind and what we might want to consider presenting for the future. So please take a look at that and help us out. In the meantime, please, everyone, through this holiday season, please stay safe. Please stay well. Please follow the CDC guidance on traveling and masking and distancing and hand washing and I don't know what else, John, HVAC exchanges. Please enjoy the remainder of your semesters. Thank you all so very much for tuning in. And Aaron, Stephen, and John, from the bottom of my heart, thank you. Be well, everybody. Bye-bye.